Welcome everyone to ECHO Palliative Care for Humanitarian Health Workers introductory course. Today is for batch 3 webinar 7 and today's topic is communication in palliative care. I welcome you all to join the session and we are running this session at 8:30 p.m. Bangladesh time. Like other days, we will have the first part in which we will have a didactic lecture on communication in palliative care. And during the lecture, all of you are welcome to write in the chat box if you have any question. Right after the lecture, we will go through the question and answering session, which will last for 20 minutes. And all of you are welcome to write or unmute yourself and raise your virtual hand to express either your comments, questions, or any experiences related to this. And our today's session, the speaker is Dr. Megan Doherty, who is a palliative care physician from Canada. She works as a program director for Two World Cancer Canada. Megan, you will get 20 minutes for this session, and our colleague Saiduzzaman will give you a notification 1 minute ahead before you close the before you wrap the session. And after that, we will have one case presentation. I will introduce our second speaker after the question and answering session of the first one. Before I hand over to Dr. Megan Doherty, it's a request to all of you, please keep yourself unmute unless you are talking or unless you have a question. And if possible, keep your camera on so that we can see your expressions and other things. But if it's related to the network availability, that's absolutely okay for us. We have Bangla speaking faculty members who are always monitoring the chat. So any of you who are comfortable with Bangla, please write in the please write here in chat box, and definitely we will respond to this. Over to you, Dr. Megan. Thank you.
Good afternoon and good evening to you all. And I'm very pleased to be with you. And I'm just to let you know, I'm replacing Dr. Rumana, who is having some urgent medical issues with her family. And I know many of you are having similar challenges, and we're thinking of you so much these days with the COVID wave that's going through Bangladesh. So I'll just summarize what was discussed in the video about communication in palliative care. So I think one important point we want to really emphasize is that communication has some really important skills that we all need to practice. One of them is listening. So we need to talk less, listen more, and allowing silence to be a tool to help us be supportive. And so you might think when you're not talking that the patient isn't getting any support from you, but sometimes we talk too much. We don't give time for the patient to think and process and accept what we've said and ask their questions. So that's why we talk about in palliative care silence being very important. And then our nonverbal behavior. And so this is that when the patient is talking, that we look like we're listening, and we nod our head and we make eye contact and we lean in a little bit and we sit and we listen to what they're saying properly, so that we really show that we're engaging with them. And that can be supportive. Even if you can't fix any problem that they have, just the way you show that you care, they will remember that. So a little bit more, what are the key parts about active listening? So in typical conversation, it's nodding your head occasionally. It's trying to avoid interrupting the patient, encouraging them to speak. So when they say some things, if there's a pause, you can just say, yes, tell me more. Like don't start talking a lot, just kind of show that you want them to keep talking. We talked about the body language, the eye contact, open posture. So open posture means not crossing your arms and sort of having a body that's open so they feel like, okay, I can talk. And sometimes we do a little bit of paraphrasing, where if the patient says something, then we can say it back. So if the patient's telling you all about their disease and how worried they are, you can say, you know, you've really shared with me a lot about what's making you really worried. And so you just kind of summarize what they said so that it tells the patient you understood them and you heard them, and they can correct you if you've misunderstood. When we use silence, it's giving the patient time to think about what they're going to say next. It's giving them space to express their own feelings, and it's making them feel like they're not so rushed. Okay. And silence is good because in medicine, if you look at how long we spend before we interrupt the patient, on average, when the patient starts talking to us, we only let them talk for 11 seconds before then we interrupt and say, oh, I have a question. Can you tell me about this? And so allowing silence and not interrupting is important. Patients feel better. It's therapeutic for them. Here are all the parts of the nonverbal communication, and I tried to find some pictures that show a really good interaction in this case with a doctor and a child patient. And here is myself and Dr. Momina, who's another doctor in Bangladesh, talking with a mother at a hospice in Bangladesh. And in the video, you may have heard about spikes, which is a way for breaking bad news. In the Bangla speaking video, there was a good summary of spikes. So spikes is 6 steps that we use to break bad news. And I think we'll go through each of them in a little bit of detail, just so you have an idea of some of the things we need to think about. So we do setup and staging. So this means before you start the conversation, you think, where can I have the conversation so that it's a little bit more private, that you're not going to get interrupted in the middle of telling the patient bad news. You make sure you prepare by reading the chart, checking the medical facts. You would ask the patient, who do you want to talk to with you? Like if they're an inpatient, you might say, do you want your family member to be there? Other members of the healthcare team, if you have like a psychologist on your team or a nurse, palliative care nurse, whomever is available, you would ask them to join you. Ideally, you would sit down if chairs are available, so that the patient feels less rushed. When we sit, everybody feels like we're taking more time, even if we give the same amount of time. We introduce everyone and we allow for enough time. Now, you may be worried that you don't have a lot of time. You don't have hours to spend with each patient. But even if you just do these things and you spend the same amount of time with the patient feels like you spent more time. So these are a way to get free time. Then the first thing we do when we're in this conversation, we do some general, introductions. How are you? How are you feeling? But when we really get to the point of the meeting, we're going to say, what have the doctors told you about your condition? What is your understanding of what is making you sick? And this is trying to get their perception of what's going on. Maybe this is helpful because they already know what's happening. Then you know that they know. And then you can just say, yes, that's correct. Like if they say, well, the doctors have told me that I have this mass, this tumor, and they said that it won't go away and it's getting worse, then you can it makes your job easier. You can say, yes, you're right. That's what's happening. I believe as well. Then you ask invitation. So you say, can I tell you more about what is happening with your condition? And sometimes people are wondering whose job is this? So what we are saying is that the doctor will do this first, and then the nurse can give a more elaboration or repeat the same message after that first meeting where the doctor has told the information already. So the nurse can give clarification, because sometimes the nurses are wondering, can I do this first? Now, there's nothing to stop you, but traditionally in the hierarchy of the medical system, then usually the doctor is expecting this. But if you work on a palliative care team, many times the roles are more overlapping, and we do have nurses who break bad news and tell the patient what's going on. But in a traditional system, the doctors are not expecting that the nurse would tell the patient. So if you're a nurse, just first make sure you clarify if that's what you're going to do. So after we do that invitation question, then we give knowledge, information about what's going on. And you give it in small pieces. You might say something like, you have a mass and this is called a tumor, or it's called cancer, and then you wait a second to make sure they don't have any questions. And then you'd say, in this case, there isn't a medicine or a treatment that can make this go away because it's very hard to treat these things, this cancer. And you go in short little bits like that. And you check, you say, if you're not understanding me, please let me know. Please ask questions. You could say something like, sometimes I use words that not everyone understands. Please stop me if you don't understand. because otherwise a patient doesn't know that they can interrupt and say, sorry, I don't understand, right? They're nervous, they're scared, they don't want to say anything. Then we have empathy and emotions. That's this next step in the SPIKES protocol. So you have to show that you also feel bad about the situation, that it's very sad for you. Now, you don't want to cry and get too worked up, but you have to give time for them to feel their emotions. If you see that they're crying or they're angry, they're shouting, then you should stop doing the breaking bad news. And you could say, once you've given time for them to recover a bit, you say, can you tell me what you're feeling or thinking about? I see that you're feeling some strong emotions, and just allow them to share a little bit. We don't have time to go in today to all the detail of how you manage the emotions, but just to acknowledge them is important. And then the last step in the SPIKES protocol of breaking bad news is to just check that they understood. So say, do you have any questions about what I just told you? Review the plan for what you're going to do next, and then write the discussion in the patient's file. Say, I did the breaking of the bad news. I told the patient they have cancer. The cancer is not curable. I recommend this treatment. Write that down so other people know what you've done, because it's very helpful for the next doctor. And here's a few additional tips. So, very hard about prognosis, right? Sometimes people say, well, how long do I have? And it's very hard to know when someone's going to die. So don't give an exact number, because you will never be right. You will always be wrong, and then the patient will not believe anything you say. So I usually give estimates, days to a short number of weeks. If you think the patient is going to live longer, like weeks to months, or you could say many months. And when you say many months, you might say, what I mean by many months is like 3 months or more and more. A few other things that we've talked about before is avoiding the phrase, there is nothing more we can do. Instead, we can say, although there is no cure for this illness, we will continue to help you and be with you and help you manage your pain and your other symptoms. We shouldn't say, I understand how you must be feeling, because we don't know what they're feeling truly. You could say, I can't understand how you must be feeling, or you can say, this is very challenging. Tell me how you're feeling. So those are just a few key summary points, talking about good communication and how it's very important in palliative care. I think this is one of the very core areas of palliative care. We've taught you about symptom management, about pain, about managing other symptoms beyond pain. Then that's one key part. And then we think that communication is the next key part of palliative care, and is very difficult. It's very challenging. So we're going to spend time talking about it and giving you advice about how to manage it. We talked about these 3 key skills that we have, which is active listening, allowing silence, and using our nonverbal behavior. And then I've gone through the SPIKES protocol, which is a way to help us know how to break bad news to patients. And we are going to post a video about breaking bad news using SPIKES. We're just preparing a video on that topic. So we'll post that to YouTube and share it in WhatsApp very shortly.
Thank you, Megan. Looks like nobody have any question to write in the chat box, and I hope all of you have already watched the Bangla recording video also on this topic in communication. May we have some experience from any of you? I could see many doctors and nurses are here, and a few of them already working in palliative care. If you could write any of your experience or thought related to the communication in palliative care, or difficulties in your settings, in your context, we would love to hear from you. You can write, or you can simply unmute yourself and you can express. প্যালিয়েটিভ কেয়ারে কাজ করছেন এরকম কারো যদি কমিউনিকেশনে কোনো সমস্যা হয়ে থাকে অথবা কোনো ভালো অভিজ্ঞতা থেকে থাকে, কেউ যদি আমাদের সাথে শেয়ার করেন, আমরা শুনতে চাই আপনার কাছ থেকে। আপনি চাইলে লিখতে পারেন চ্যাট বক্সে, অথবা আনমিউট করে বলতে পারেন আপনি যেটি বলতে চাচ্ছেন। ধন্যবাদ।
Sometimes people find the biggest challenge is finding a place and a time to do the communication. And that can be very hard. We recommend that we don't do it on our daily rounds. If the patients are inpatients, take time after the rounds if you can. It's not in rounds you feel rushed. There's lots of people around. Other patients are listening. And ideally, we don't want to do it at the bedside, because if the patient gets very upset, starts to cry, it's gonna make all the other patients a bit upset. So it's, if we can find a corner, even if it doesn't have a, it's not a fully a closed room, but even just sort of a side place on the edge of the ward, you know, just outside somewhere where we can have at least a little bit more privacy also, so that all the other patients aren't listening in. It's sometimes good.
Hi, this is Anne. Can you hear me okay? Let me see if my
Perfect.
camera will work. I also thank you, Megan. That was great. I also think it can be helpful after you're sharing that news to ask like the surprise question, like, does it surprise you to hear this information? Or does it surprise you to hear how sick you are? And that's worked well for me.
Thank you. That's a really good question. How would you translate that question in Bangla, Tasneem? Because that's a really good question that can be very supportive.
আপনি জিজ্ঞেস করতে পারেন, আপনি কি খুব আশ্চর্য হয়েছেন আপনার যে রোগটা নির্ণয় হয়েছে এটা শোনার পরে, অথবা আপনি কতখানি আশ্চর্য হয়েছেন, আপনি কি আশা করছিলেন যে আপনার রোগটা কি রকম, অথবা এটা শোনার পর আপনার কাছে কি রকম লাগছে। আপনি বুঝতে পারবেন তার কাছ থেকে শোনার পর যে তার মানসিক অবস্থাটা কি, সেক্ষেত্রে আপনার পরবর্তী কনভারসেশনটা আপনি গুছিয়ে নিতে পারবেন। Megan, I would love to hear from healthcare workers here, those who worked in SARI ITC. Last year, I did in-person training for the healthcare workers who are working in SARI ITCs. And we divided it like mild, moderate, and severe, how you could break the, how you do the breaking of bad news. Anyone who experienced, I will look for the people who are working in Cox's Bazar Rohingya camp, even others are also welcome, please.
Hello, can you hear me?
Yes, please, we can hear you. Carry on.
Thank you. I'm Dr. Lutful Haidar, working as a medical officer at IOM, Palliative Care Department. So regarding communication in palliative care, I think we are trying to communicate with active listening, and when we give them time and the facial expression or body language, they feel much faithful with us. And though language is a barrier in the Rohingya context, but in my little experience, I can say that they are feeling hope, or they are feeling faithful, and they feel that they are getting some time that they can express their feelings, or they express their sufferings. And in the normal setting, they cannot find that time to explain their sufferings with the healthcare professional or other person. But in palliative care, they have the time, or have the way to express their feelings. And I think we cannot find any case, so much case for breaking bad news, as they are already know their diagnosis. And if we ask the patient or sufferer about their condition, they already we are saying that they already know their condition. And when we communicate with the person or their family members, they express their feelings, or they can feeling hope with us actually. Thank you.
Thank you, Dr. Lutfur. Happy to hear from your side how it's going on inside the Rohingya camp. And I agree with you that the time while we get the patient, even for me, the worst case was patient came to me and said that you are not believing I'm a patient of this carcinoma. So it's like they already received chemotherapy, and without knowing what will be the next plan, they are moving from one place to another, one health center to another health center. It's true. And I'm really happy to hear from Dr. Megan that there will be another video on breaking of bad news. We understand the context, the scenario could be different in many places around the globe, but still knowing the basic would be really helpful, not only for our patient, but also ourselves, how to cope up with this session. And from the lecture, we just heard that before once the patient starts talking with us, as a physician, we allow 11 seconds to go to the next topic or raise our questions. So it's really important for all of us to understand how to tackle this situation and how allow people that we are here to listen about yourself. We are almost at the end of the first part of today's topic, and we will go to the second part, which is a case presentation. Dr. Gillian Floyes will do the case presentation for us. She is a palliative care physician from Canada. Over to you, Gillian.
Thanks, Tasneem. Saeed, are you going to share the slides, or do you want me to do it?
I'm sorry, I don't have any slides for that.
Okay.
Did you share it already?
Yeah, well, that's okay. I can share.
Yeah, sure, please. Go ahead.
So there, are you guys seeing those slides? I think you are, right? Yep. Okay. All right. So I'm going to go through a case with you, but I think we should, could acknowledge how difficult this is for all of us, healthcare professionals. This is one of the most stressful things that we can do as healthcare professionals, is breaking bad news and having these really hard talks with patients. And if we learn to do it, it improves our satisfaction with our job, reduces our stress. I know you guys are doing this all the time. And having a sort of a structure that you can think through helps reduce some of that stress, I find, certainly. And if you find the Spikes structure useful, I think it can help you have these conversations and make it a little bit easier and make our jobs a little less stressful. So we're going to talk about a case, and I really hope to get feedback, and it's going to be hard for me to see the chat, but there you go. Okay, so this is a 65-year-old man. He came to see you in the health center 2 weeks ago. He was complaining that he had pain in his chest and in his belly, and he told you that 2 years ago in Myanmar, he had lung cancer in his right lung and he had surgery. His wife came in with him to the health center to see you today. And he's got 2 grown daughters and he has 4 grandchildren. All of them live nearby in the camp. When you saw him 2 weeks ago, you examined him, you took his history, you found that his liver was very enlarged and hard, and you thought that he probably had fluid in the right chest. So you were worried about him. You sent him off for CAT scans and a tapping of the pleural fluid. And what you know is that this showed that he has lots of cancer. The lung cancer has come back in his liver, in his lung, and he's got fluid. Now, he told you when you saw him 2 weeks ago with his wife that he was cured. So the surgeons in Myanmar told him he was cured. So he's coming back to you today to get the results. So any thoughts so far about what's sort of standing out for you there before we go any further? What's what is a complication there that you may have to deal with? And I'm having trouble seeing the chat, so not popping up.
Nothing in the chat right now. Please.
What was the
Sorry, say that again.
What was the question? What are the modalities or?
Jillian, you're
Yes.
muted.
Just imagine the case and think about yourself that you are the doctor who will handle with this case, or you are the nurse who will handle with this case, and you can start writing in chat box, or you can unmute yourself and you can talk what you're going to do with this situation.
So just to get us started. So how often do you experience situations where somebody comes to you with generally cancer or very advanced disease, and another healthcare professional has told them they were cured or that it's all gone away? And you're gonna, in addition to having to break the bad news, you have to deal with the fact that this person thought that they were cured. This is not an uncommon thing in my setting. Is that something that you guys see? Because it can complicate the discussion. Right?
Yes. Yes, it's of course a very hard to explain because of, as the patient already thought and perceived that she or he was cured, so he is emotionally liable with that. So maybe it's we can start that, explain the disease recurrence, and there is a sum of biased information that it will totally cured. So let the discussing with the patient about the recurrence of the disease, which not the fault of the any previous procedure or any other medical therapy. So it might be possible, and there is the metastasis also, which is might be undiagnosed in that time. So that's why it's recurrent. And let's tell about the now what are the modalities that we have and what can we do for him, for his or her well-being.
Lovely, thank you. And we'll talk about that more as we get through the spikes. So, right, okay. So thank you. And Anne has put in the chat, which I can now see, language and word choice is important. So try to be very clear. Not everybody knows that tumor means cancer. I had a patient who told me he didn't have cancer. He had very advanced cancer and had been treated for many, many months, but everybody used the word tumor and he didn't understand that that meant cancer. So make sure you're clear. So Anne has put some really good suggestions and ideas in the chat. So let's go on a little bit, and we're going to go through in detail the spikes. So this is the setup, and this is before you go in to see him. So, and Dr. Meg can talk to you a little bit about this. So let's go to the first point, outline the steps you will think about before seeing him. So you've gotten these results back. You know he has very advanced cancer. You need to be ready and to have spent some time before you go in to talk to this man and his family to ensure you have all the information. So what things are you going to think through as you're preparing for this visit with this man? What do you need to know? You will have reviewed the chart carefully. You reviewed the scan, so you make sure you know, and that you're not flipping through pages when you're sitting with the person, right? What else would you do? What would you think about regarding who's coming with him? Would you want this man to come in by himself? And again, I can't see the chat anymore. So.
Daughters.
Go ahead. So could you make sure that his family comes with him, or his wife comes with him, or you could arrange this in advance, right? And if since when you saw him 2 weeks ago, you suspected that his cancer is back, you probably would have said, come back in 2 weeks and bring your family with you, because we'll review the scans. Yeah.
আপনারা কি মনে করেন যে পেশেন্ট যখন আপনি যখন ডক্টর হিসেবে বা হেলথ কেয়ার প্রফেশনাল হিসেবে আপনি যখন এটা ফাইন্ড আউট করলেন যে এটা একটা ক্যান্সার, তখন আপনি কি পেশেন্টকে সরাসরি ডেকে বলে দিবেন, নাকি তাকে বলবেন তার ওয়াইফ অথবা তার যদি কোনো পুত্র বা যদি কোনো মেয়ে থাকে তাদেরকে নিয়ে আসার জন্য, নাকি আপনি আরো 1 সপ্তাহ অপেক্ষা করবেন তাকে এই নিউজটা দেওয়ার জন্য? আপনারা যে কেউ চাইলে বাংলায় বলতে পারেন, এখানে যেহেতু আমাদের ফ্যাসিলিটেটর ভালো বাংলা থেকে ইংরেজিতে কনভার্ট করে হচ্ছে জিনিস প্রেজেন্ট করছেন, তাকে বুঝিয়ে বলতে পারবেন, এবং তিনি যখন অ্যান্সারটা দিবেন তখন সেটাকে আবার বাংলায় আপনাদের জন্য বলে দিবেন। তো আপনাদের অ্যাক্টিভ পার্টিসিপেশনটা হচ্ছে যে একটু বেশি আর কি দরকার। ধন্যবাদ সবাইকে।
Thanks,
We
Said.
should
We wish
consider,
we wish this course to be very interactive. So please respond either in chat box or unmute yourself. If you are not understanding, if you look for Bangla translation, we are here to do that for you. Please. Thank you.
so regarding the breaking bad news of the patient, we should consider a dialogue with, of course, with their family, because of it's a matter of fact that already the whole family knows that she or he might be cured. So we need to, of course, try to arrange a very counseling way along with the caregiver. That means the family members. This might be his or her spouse or daughter or child. So who will be the caregiver? So we need to counseling everyone and breaking the bad news. But if it's not possible, then we also go for the patient's willing, that if because of its he is right to know about the prognosis and about the disease also.
Right. Okay, thank you very much. Okay, so just to think a little bit more about, and you're quite right, about how you will prepare yourself before you're going in to see this man and his family. You're going to think through what you're going to say, how you're going to say it, and you will also have a plan before you go in regarding next steps, right? What you can offer this man and what you can't offer this man. Right? So you need to prepare yourself, do your homework before. Okay, so let's then go through the spikes one by one. So Dr. Megan has gone through this, and you've seen this in the video. It's very useful and can help, as I said, reduce the stress and anxiety that can go on with this. So the spikes is the setup, perception, invitation, knowledge, emotion, and the summary. Okay, let's go one by one. So we talked about the setup and the important considerations already for the setup. I think we got through most of that. Thing we didn't talk about is, do you need a translator? And I don't know how common that is in the camps, that you need to bring a translator, or if there's usually somebody there who can translate. Ideally, you would not have a family member translate. Right? So is that an issue that you need to bring translators or have a colleague translate?
Jillian, there was just one thing in the chat regarding the setup, or the first thing. Mohammed Habib said, at first tell patients' family members.
Okay,
So I'm not sure if you wanted to comment. I don't know if you're seeing that, but if you wanted to comment, if we first tell families and then we tell patients, or how that works.
yeah, we're going to get to that. Thanks, Erin, because we are going to get to that. That's a major issue and something we should absolutely talk about, because it's different in different settings, isn't it? Okay, so
Hello, can I ask a question here?
yes.
Because when a child is in the hospital under critical condition, sometimes we saw that the caregivers are different types of caregivers, like the aunt, sometimes the mom, if the patient is staying here for the long time, and the father, even the mother and aunt. So during regarding the providing the news, so what did any assessment, like we have to give the directly mother or father, or we can consider the other caregiver also? Like, did any kind of instruction for this kind of messages?
Okay, I think, are you asking how many different family members should be involved, or
Yeah.
or it's the same question that Erin flagged from the chat? And why don't we talk about that now, since it's come up twice? So regarding how many family members get told, I would suggest that the patient gets to decide that. But so let's jump up a little bit in the spikes and talk about when you're going to give the bad news. Do you go and talk to the patient and say, who do you want to be here when we talk about the results? Or do you go to the family first and give them the information first? And the last time we did this, when we did batch 2, the participants said that in the camps, generally, the doctor would go and talk to the family members outside the room first, and then go and talk to the patient. So I'd be really interested, but then others said no, that it's not done that way. And sometimes it depends whether it's an acute care setting or a clinic or a home setting, that you go through the spikes and you ask the invitation about, I would like to talk to you about what's happening. You can also say, how much information would you like from me about what the scans showed? And then the patient directs how much he or she gets told and who's there. So let's get some feedback there, because I know there are differences in different settings in different countries and different parts of the country.
I'd like to hear one more thing here, because in the Rohingya context, sometimes we saw that regarding the caregivers, like the grandfather, grandmother is more involved in this kind of cases, and the father and mother is also there. And differing the decision maker in the family, because most of them are living in the joint family. So sometimes it's differs. Like talking with the father, sometimes it's very easy to understand because of the understandability. And sometimes with the mother, decision making is from the father's side, like the male person of the family is taking the decision. And sometimes some family, the grandmother plays the main role. So it's very difficult to understand, like, okay, I have to provide the bad news, and whom I'm going to giving the news for the next decision making for the patients and for the condition. So I think it's depends so many things. And from your side, actually, what is your opinion regarding this?
Okay, so thank you. So one of the ways I would suggest that you could sort that out a little bit is, the first time you saw this man, for instance, you examined him and you thought, this is bad, the cancer's probably back. And so you asked him to come back in 2 weeks. At that time, you could say, we'll have the results back. We may need to make some decisions about next steps. So who do you want to be there? How does it work in your family? Who are the important people who need to be there? Okay, so establish that in advance if you can, and you know that likely you're going to give this man bad news. Okay.
Gillian, may I interrupt?
Absolutely.
Thank you. Just to let you know, Mr. Fazle, I don't know whether you work as a medical doctor.
I'm a psychologist. Yeah, I'm a
psychologist. From my side, there is no wrong answer. Like, if you think, it depends on your situation. And while I started working in Rohingya camp, I came to know from different sources that 25,000 children living in Rohingya camp actually have no parents at all. I mean, they're the orphan. So fortunately for me, I did not get any patient or any children who are suffering from incurable diseases, but they don't have anyone to respond or parents like this. But in different cases, I got patients who used to speak that, yes, 3 of we are staying together and we don't have parents. So the situation was different. I will translate something in Bangla for all the Bangla participants regarding the last session, what we did and what was the response from that session. গত সেশনে আমরা যখন এই টপিকটা নিয়ে আলোচনা করেছি, আমাদের জানতে চাওয়া ছিল যে আপনারা কার কাছে আগে বলতে চান, রোগীর লোকের কাছে নাকি রোগীর কাছে। 2 ধরনের রেসপন্সই আমরা পেয়েছি। কেউ বলেছেন আমরা আগে রোগীকে বলবো, তারপর রোগীর লোকের কাছে যাব। আবার কেউ বলেছেন যে না, এটা ভালো, আগে রোগীর লোকের সাথে কথা বলে তাকে জানাবো কি জানাবো না এই ব্যাপারে সিদ্ধান্ত নেওয়া। আপনারা যদি আপনাদের মতামতটা চ্যাট বক্সে লেখেন যে আপনারা কে মনে করেন উই শুড গো ফর দ্য পেশেন্ট ফার্স্ট, আমরা রোগীকে প্রথমে বলা উচিত, অথবা রোগীর লোককে প্রথমে বলা উচিত। আপনারা চ্যাট বক্সে লিখতে পারেন এবং বলে রাখা ভালো এখানে কোনো ভুল উত্তর নেই। আপনার পর্যায়ে আপনি কিভাবে অনুভব করেছেন সেই অনুযায়ী আপনি লিখতে পারেন। ধন্যবাদ। Over to you, Jillian. Thank you.
Thanks a lot, Tasneem. So I can intermittently see the chat, and there's some really good comments in there. So to get back to the question about extended family members, again, if you can set that up and find that out in advance, that's excellent. But again, as Dr. Catherine and others have said, the patient should get to just, is the person who gets to decide who gets told when. If the patient wants to be told first, the patient should get to be told first. If they want their family members, then that's their decision, right? And I know that there are nuances to this in different places. Okay, so let's go on to perception. And there's some nice things in the chat. So this is the second part of the spikes. This is when you're finding out from the person, from the patient, what their understanding is. And Sumaya's put some nice examples in the chat. Do you know what is making you sick? What have the doctors told you about your condition? Any other words that you would use to try to determine what the patient actually knows? Dr. Megan has taught you why it's important that we know where they are. This man thought he was cured. Okay, so think about those sentences. It's helpful to have sentences that already in your head that can make it easier. So what have you been told? What do you understand about what's been going on with your cancer? Okay. And Anne has put, as a social worker, I often ask, what have you been hearing from the doctors? Yeah, thanks, Tasneem, putting that in. Okay, let's keep going. So the next step is invitation. So this is the invitation about how much information do you want from me? Would you like me to tell you about what's happening? Or would you like me to talk to your father, wife first? What words would you use to ask the patient what they want to hear and how they want to hear it? What's worked for you?
Gillian, do you want to share some examples of what's worked for you?
Yeah. So I often say, how much information would you like from me about what the scans showed and what's happening and why you're having the pain in your belly and in your lungs? Okay. Or I'd say, you know, if it's a patient that I've known, I say, I think I know the answer to this because I've known you for a long time. You always wanted to know everything. But how much would you like to hear from me today? And would you like me to talk to your family members first? Would you like me to talk to your father? And then you wait to hear what the person says. If the person says, I don't want to know anything, that's difficult. But if they say, I don't want you to tell me, then you stop because the person doesn't want to know. In a setting like this, with this man who's got very advanced disease, I would say, okay, I understand that. Would you like me to talk to your family about the results? Okay. And generally, the person will say yes. If they still say no, and because I would know that this man is going to get sicker faster and will need some symptomatic treatment, absolutely, and support for he and his family, I often say things like, okay, I understand that you don't want to hear the results or to have your family hear the results, but I'm worried that if you knew what the scan showed, it would change what you decide to do and you might make different decisions. And then stop. Okay. And Anne's put some things in the chat about how's your body feeling. That's really good. Okay. So do you think that though you could use those words? How much information do you want from me? Do you want me to tell you what the scan showed, or do you want me to tell your family? Yeah, and in this chat, the patient has the right to know, so he should be informed along with his family. Yeah, the patient should be the one who gets to decide. So many of you on the call must have had these conversations quite a few times, right? Anything that worked really well for you, or anything that went really, really badly that you learned from? Okay, I'm going to keep going then. All right, so I hope you find some of those sentences helpful. So knowledge. So this is when you're relaying the information. So the person has said, no, tell me, my wife is here, I want to know. So what would you say? You know that the scans have shown that he has extensive cancer in his liver and back in his lungs. So how would you say this to him in a kind way? We use the term gentle directness. So you'll be direct and tell him clearly, but you'll be gentle. And we talk about this thing called a shot across the bow, which I don't know if that translates very well, but that's just a little warning that something bad is happening, even a few seconds before. It's just a little warning. Oh, some bad information is coming. The person can sort of, okay, get a little bit ready. Okay, the warning shot, yeah. Okay, so any ideas, or should I give you some examples? I'll give you some examples. So what you can say is, all right, so you know that when you came in 2 weeks ago, you had pain in your belly and in your chest, and you'd had the cancer cut out 2 years ago. We did the tests because I was concerned about whether the cancer might have come back. Stop, let that sink in for a few seconds. And I would say, and I wish I didn't have to tell you this, but the cancer has come back. And then I might pause a little bit, because the person's probably going to be shocked, maybe shocked and distressed. And then eventually go talk about how it's in the liver and also back in his lungs. And then you stop. Okay. How does that sound? So you get everybody on the same page. This is why we did the scans. Give them a bit of a warning shot. I was concerned that the cancer might have come back. And then you clearly give the information and then stop. And this is what Dr. Megan was talking about, pauses and silence. Okay, is that something you think you could try? Okay, so we're going to the next one. So the emotions, the empathy. So this, I really do need to hear from you guys now. How do you acknowledge these? What do you do? So you've just given this man this information, which is pretty devastating. And he and his wife are upset and crying. What do you do? What's appropriate to do? You know, there's some, is touching an arm appropriate? What would you say? Yeah, empathy must be needed. Yeah. What are some ways that are appropriate for you to do? Is it appropriate to touch his arm for you in your settings?
আপনি যে সেটিং এ কাজ করেন সেখানে রোগীর হাত ধরা কি স্বাভাবিক না অস্বাভাবিক? আপনারা ইয়েস নো লিখতে পারেন এই খবরটি জানানোর সময়।
How would you say it? Would you say, you don't, Would you say, I can see that this is very upsetting for you? Can you tell me what you're thinking now? Yeah, something you guys would say? Yes, thank you, Dr. Hamid. I think touch depends patient to patient. Yes, yes, okay. All righty. And you sometimes need to stop. If the person is very distressed, stop and suggest that they come back in the next day or two, but making sure that they're okay and that there's somebody with them and that you're going to follow up shortly if they're so distressed, because you need to go next steps about how to help this man and his family, right? Okay, lots of yeses, thank you. Okay. Okay. So then to summarize, so you have already thought, yeah, go ahead.
So as we are working in Rohingya camp, so if someone is diagnosed from HIV/AIDS, there is some barrier for the society, and mostly the community is like conservative. So it happened in my first experience that when the physician declared that someone is diagnosed from HIV/AIDS, so the patient party with their neighbor came to attack the physician and the facility. So is there any suggestion regarding that? How we can approach this kind of situation?
Okay, I didn't catch all of that, Saeed. It was about approaching a patient with HIV/AIDS and the neighbors. Was this about fear of infection and stigma? I didn't catch all of that.
Yeah, this is mostly related with the stigma. As the people are very much conservative in terms of religious view. Yeah. So after declaring this kind of disease, the patient party with the neighbor came to attack the facility. So what will be the approach in that case? To communicate, yeah, sure. Okay,
to communicate to the neighbor about the risk of getting HIV/AIDS because they're nearby. I think that's what you're saying, Saeed. So I'm going to assume that's what you're saying. So patient confidentiality is important, right? You can't be giving information to a neighbor about that patient unless the patient says it's okay. I mean, this is a big issue, isn't it? And in lots of places, community members are worried that cancer is catching as well, that cancer is infectious, and people get with these diseases get isolated because neighbors were worried they're going to catch cancer or catch AIDS. So you can't discuss this unless the patient says. It's more of a role for community sessions, community awareness sessions, which I know are difficult to do. You can demonstrate by being healthcare professionals who go and see that patient, go and see that family. I don't know if there's any other things that Tasneem or others, Tasneem's hands up, that you will do specifically in that setting.
Yes, Jillian, I just want to mention one of my worst experience with HIV cases and confidentiality and the training we have, as a medical doctor. In comparison to other parts in the world like Africa, I don't know the exact status of HIV percentage or how many of our population are already infected. Nationally, I don't think we are in a really good stage to give something clear cut. And some stigmas are already going on. So what happened while I started working in Rohingya camp, it was by medical doctors who were writing that be aware that camp, for example, Camp 13 having HIV patient in this block. So everyone please be careful. So that time I had a real problem to manage duty doctor for that camp. The level of understanding or confidentiality level was like this. It is spreaded among all the doctors, and they said you can put me on duty, on roster duty in any of the camp except Camp 13. for example, Chem13, I'm giving the example as Chem13. And Said was saying about the spread of the news among the community people and others, which might get violent, not only in the Rohingya camp, but also other settings in Bangladesh. So we would love to hear completely differentiation about HIV and HIV palliative care for HIV patients. And I'm pretty sure IOM was on a stage to plan the HIV patients program, especially in palliative care, in a very different way while I was working with palliative care. We can discuss it later. You can carry on. Thanks, Said.
Yeah, thanks, Said. That's really great that you brought that up. And just to finish up, so you can't talk to a neighbor without the patient's consent about the specifics, but you can talk generally about the myths and the truth about transmission of HIV/AIDS. So, okay, so thanks, Jasmine, we got that message. Catherine, I think you had your hand up.
Thank you. Yes, thank you, Gillian. I'm going to keep my video off because my signal's not great. There was a bit of confusion in the chat about how bad news should be broken. Should it be given to the patient or the family? And I just wanted to address this one, if that's okay.
Yes,
so
yeah,
information really belongs to the patient. And so if you have any updates or news or diagnosis or bad news to break, it ideally should be with the patient if they are willing to have that information. So we need to ask them, do you want to have information about your condition? Do you want to have updates, even if it's bad news? They may decide, actually, no. And sometimes people are from a culture where families would take the information, or maybe they just prefer it that way. They don't want to hear anything of their condition. Please tell my family. In which case you follow the patient's wishes and tell the family. Now, I think the difficulty comes in where a patient wants information, but the family do not want the patient to have it. And perhaps Tasneem will speak more for the culture in Bangladesh, but and in Rohingya. But what can happen actually is that if there is a cultural norm that the family receive information, sometimes the family may think that if the person is told what's happening to them, they will become depressed, they will die more quickly, they will give up. And so usually family has good intention for not wanting the patient to know. However, if the patient wants information about their condition, what I would recommend to do is speak to the family and explain to the family why it's important that the patient has the information that they're asking for. And the reason we take this approach, rather than just giving the patient information, is because we want to avoid conflict, because conflict between the doctor and the family, or between patient and family, is difficult for everybody and nobody benefits from that. So if there is conflict about who should receive information, please speak to the family and explain why you want to answer the question, why you want to give the person the information they are looking for. And you can tell them things like, it's the person who's living this experience, it's their illness and they have a right to know. It can allow the person to plan. It can allow the person to make important decisions about their healthcare, which you can't do if you don't have the information, and to choose where they want to spend their time. For example, do they want to be at home with their family? Do they want to stay in hospital? So the approach I would recommend when there's a difference of opinion about who should receive the information would be to do exactly that, have a family meeting and try to have the family understand why it's important. Sometimes even this doesn't proceed and the family say, no, really, the patient should not know. In this situation, take permission from the family to ask the patient, if you can ask the patient what they think is going on. So rather than give information, what do you think is happening to you? And quite often the patient will know that the situation is bleak, that perhaps they're approaching end of life. And that way you allow honesty and connection again, because maybe they have not been able to share that because their family have been optimistic. So that's just a couple of ideas of how to approach the situation when there is conflict of who should have information.
Lovely, thanks, Catherine. That was very helpful. Okay, and I see that in the chat is Tasneem's put in that some healthcare workers have said that if they give the news to the patient, then he'll be worried and might die soon. And there certainly is no evidence that people die sooner at all when given that information. Thanks, Megan. Okay, let's just finish up. So the summary and the strategy. So before you've even gone in to see this man and his family, you've thought about what are the next steps that you will offer, whether it would be appropriate to offer him a referral to a larger center for further treatment, or whether symptomatic and palliative care is appropriate, which is likely the case with widely metastatic cancer. So you'll be offering or describing to this man what the next steps are, and you're certainly going to want to concentrate on symptom management, support for the family, and follow-up, right? What else would you want to make sure you discussed before this man and his family left the clinic or before you left the house? What are you going to want to make sure as an empathetic healthcare professional? What would you do before you left?
সেশন শেষ করার আগে আপনি কি করবেন একজন হেলথ কেয়ার ওয়ার্কার হিসেবে? আপনার কাছে কি মনে হয় আজকের কথা এখানেই শেষ হতে যাচ্ছে? এই প্রসঙ্গটির আগে আপনি কি করতে চান? একটু যদি চ্যাট বক্সে লেখেন অথবা বাংলা ইংরেজিতে বলতে চান।
Okay, so you're gonna arrange for a follow-up. It might be a phone call. It might be asking one of your team members to come back and check in on him that his pain is better, ensure that any questions can be answered, because he and his family are sure to have more questions and concerns. If you have a social worker or a psychologist on your team, see if the family and the patient may need some help that way. So you're going to make sure there's some sort of follow-up, right? Okay. I think that's probably, unless anybody has anything to add or any more questions. And certainly the issue about talking to the family or patient first comes up very frequently whenever we give these talks anywhere. So it's complicated, isn't it? Okay, I'm going to hand back to you, Tasneem. Thank you.
Thanks, Jillian. It was excellent.
Thank you.
And I would love to hear from our participant more and more, because you know many of you already experienced these situations, and that might not be exactly same what we do in our context, those who are working in Rohingya camp. And I could see many participants are even not from Bangladesh. So those who want to speak something, those who want to share their experience, you can do that. We will go for our Bangla summary now. Roshan will do the Bangla summary, who is a nurse instructor in Shohid Tajuddin Nursing Institute, and she has been working in palliative care for many years. Over to you, Roshan Appa.
Thank you, Tasneem Appu. Assalamu alaikum সবাইকে। যে আমরা আজকে খুব সুন্দর একটা সেশন উপভোগ করছিলাম, যে কমিউনিকেশন, প্যালিয়েটিভ কেয়ার আসলে কমিউনিকেশন স্কিলটা খুব ইম্পর্টেন্ট। তো এই কমিউনিকেশন আমরা যা শিখলাম, সেখানে আসলে প্রথমেই বলতে চাই যে কমিউনিকেশনটা কি। এটা একটা টু ওয়ে প্রসেস, যেখানে রোগীর রোগ চিকিৎসার ধরন বা পরিণতি সম্পর্কে জানতে পারবে রোগী, এবং পাশাপাশি রোগী বা তার পরিবারের এনজাইটি বা ইমোশনটা প্রকাশ করার জন্য অনুপ্রাণিত হবে। এই কমিউনিকেশন যত আগে শুরু করবে, ততই রোগী বা তার পরিবারের জন্য ভালো। তাতে রোগী বা তার পরিবারের কোয়ালিটি অফ লাইফটা ইমপ্রুভ করে অনেকটা বেশি, তুলনামূলক ভালো। আর আমরা এখানে যেটা তিনটা বিষয় খুব গুরুত্ব দিয়ে শিখছিলাম, সেটা হলো যে কমিউনিকেশন স্কিলস এর তিনটা মেইন পয়েন্টস। একটা হলো অ্যাক্টিভ লিসেনিং, একটা ইউজিং সাইলেন্স, আর একটা নন ভার্বাল বিহেভিয়ার্স। অ্যাক্টিভ লিসেনিং এ যেগুলোকে গুরুত্ব দিচ্ছিলেন ডক্টর মেঘান, সেটা হলো যে আমরা শুনবো, আসলে আমাদের শুনতে হবে, বলার চাইতে শুনতে হবে বেশি করে, এবং যখন শুনবো প্রয়োজনে আমরা একটু মাথা নাড়াবো, একটু নোট নেব, ইন্টারাপ্ট করবো না রুগীকে। তারা যেন কথা বলতে অনুপ্রাণিত হন, সেই জন্য আচ্ছা তারপর এরপরে কি যেন হয়েছিল এইভাবে বলে তাদেরকে আমরা অনুপ্রাণিত করতে পারি যে আমরা শুনছি তাকে মনোযোগ দিয়ে। পাশাপাশি বডি ল্যাঙ্গুয়েজের ইউজ করতে পারি, আই কন্ট্যাক্টটা যেন থাকে সেটা, এবং আমরা কি শুনলাম সেটা একটু যদি সামারাইজ করি তাহলে কোনো মিস ইনফরমেশন থাকলে সেটা হয়তো মিনিমাইজ হয়ে যাবে। সেই জন্য অ্যাক্টিভ লিসেনিংটা খুব ইম্পর্টেন্ট। এরপরে বলেছিলেন উনি যে সাইলেন্সটা আমরা ইউজ করব, অর্থাৎ আমরা সময় নিয়ে কথা শুনবো, এবং যখন রোগী কথা বলবে তাকে আরেকটু সময় দিতে হবে, এরপরে উনি কি বলতে চান এটার জন্য যদি একটু চিন্তা করতে চান সেই সময়টা যেন আমরা দিতে পারি আর কি। সেই জন্য সময়টা খুব ইম্পর্টেন্ট। এবং রোগী তার ইমোশন, ফিলিংস এবং কষ্টের কথা যখন বলেন মাঝে মধ্যে ওনারা চুপ হয়ে যান, সেই চুপটাকে যেন আমরা একটু অ্যালাউ করি এবং তাড়াহুড়ো যেন না করি। বডি ল্যাঙ্গুয়েজ আমরা জানি যে নন ভার্বাল খুব বড় একটা ইস্যু, কমিউনিকেশনের বড় একটা অংশ। সেখানে আমাদের বডি ল্যাঙ্গুয়েজ, গেস্টার, পোস্টার, আই কন্ট্যাক্ট অথবা ভয়েস টোনটা খুব একটা ইম্পর্টেন্ট। আর ইমপ্যাথেটিক টাচ, যেটা আমরা বারবার শুনে আসছিলাম। আর বাচ্চাদের বেলা কমিউনিকেশনে প্লে থেরাপির একটা খুব ইম্পর্টেন্ট রোল আছে, সেটার কথা এখানে আসে নাই যদিও, কিন্তু আমরা যখন বাচ্চাদের সাথে কমিউনিকেশন করবো প্লে থেরাপির কথাটা যেন একটু মাথায় থাকে। আর স্পাইকস আমরা এতক্ষণ মানে কোশ্চেন অ্যান্সার, কেস ডিসকাশনের মাধ্যমে প্র্যাকটিস সেশন করে আসলে স্পাইকসটা খুব ভালো হয়তো বুঝে গিয়েছি আমরা সবাই। যে ছয়টা স্টেজ আছে, যে প্রথমে সেটিং অথবা স্টেজিংটা আমাদের কি রকম হবে, আমরা যেখানে বসে কথা বলবো বা যে সেটিংস এ কথা বলবো সেটা অবশ্যই যেন পাশাপাশি হয়, রোগী বা আমাদের একই সাথে প্রাইভেসিটা যেন একটু মেনটেন হয়। মাঝে মধ্যে আমরা কথা বলার সময় রোগীদের সাথে ইন্টারাপ্ট হয়, ফোন বেজে ওঠে, যেন এইগুলো না হয় এটা আগে থেকে একটু ম্যানেজ করে ফেলবো। ইমার্জেন্সি কোনো কাজ থাকলে সেটা আগে থেকে সেরে নিব। যে রোগীর সাথে কথা বলবো তার রোগ সম্পর্কে তার একটু রেকর্ডসটা, মেডিকেল রেকর্ডস, তার নামটা একটু যদি আগে থেকে জেনে নিই, ডায়াগনোসিসটা জেনে নিই, কথা বলতে সুবিধা হবে। রোগী তার সাথে কাকে রাখতে চান, পরিবারের মেম্বার, সেটা আমরা একটু জিজ্ঞেস করে জেনে নিতে পারি, নিজের পরিচয় দিতে পারি, এবং সেখানে কথা বললে তার কি উপকার হবে আমার সাথে কথা বললে সেটা যদি আমরা একটু বলে নিই, একটু যথেষ্ট সময় নিয়ে বসি তাহলে হয়। এছাড়া ওনারা বারবার বলছিলেন যে পারসেপশন নিয়ে, পারসেপশন রোগী এই রোগ সম্পর্কে কি জানেন, তার আগে থেকে কি ধারণা আছে, আমরা একটা আগে শুনে নেব রোগীর কাছ থেকে বা রোগীর পরিবারের কাছ থেকে। সে কার কাছ থেকে শুনেছেন, ডক্টরের কাছ থেকে যদি শুনে থাকেন কতটুকুন শুনেছেন, কি বুঝেছেন, সেটা আমরা একটু শুনে নেব, শুনে তারপরে কথা বলবো। এখানে একটা বিষয় ওনারা বলছিলেন যে আমাদের দেশের কালচার অনুযায়ী সাধারণত ডক্টররা আগে ইনফরমেশন দেয়, এই ব্রেকিং ব্যাড নিউজ বলেন অথবা এই ধরনের রোগীর রোগ সম্পর্কে যখন জানান সাধারণত ডক্টররা বলেন, তারপরে আমরা নার্সদের কাছে রোগীরা বা রোগীর পরিবাররা আরেকটু ডিটেলস আকারে জানতে চান আর কি। এছাড়া ইনভাইটেশন বলা হচ্ছে রোগী জানতে চাচ্ছেন কিনা সেটা আমরা একটু রোগীর কাছ থেকে জেনে নেব, ওনারা তার কাছ থেকে পারমিশন নিয়ে নেব, এবং যে উনি যা শুনেছেন বা যা কমিউনিকেশন করা হচ্ছে অল্প অল্প করে তার বোধগম্য হয়, তার ভাষায় সহজবোধ্য যেন হয়, সেভাবে একটু একটু করে বলা, এবং বলার পর আবার বারবার চেক করা সে কি বুঝতে পারছি কিনা, কতটুকু বুঝতে পারছে সেটা একটু খেয়াল করতে হবে। এবং আমরা যে তাকে বুঝতে, তার অনুভূতি, তার ফিলিংস বা তার সাফারিংসটা বুঝতে পারছি, আমরা যে কানেক্টেড আছি ইমোশনালি সেটা বুঝতে দিতে হবে। এবং ওনারা যদি রোগী বা তার পরিবার কথা বলার সময় কান্না করেন অথবা চুপ থাকেন সেটাকে আমরা একটু অ্যালাউ করবো আর কি, সেই বিষয়টার কথা বারবার আসছে। আর ফাইনালি যা বলেছি আমরা সেটা একটু ওভারঅল চেক করে নেওয়া, সামারাইজ করা, আর কিছু জানতে চান কিনা। আমাদের লাস্ট যে ইস্যুটা আসছিল জিলিয়ানের কাছ থেকে, যে আমরা যখন ক্লোজ করবো একটা সেশন তাহলে আমরা কি জানতে চাইবো, কি বলে শেষ করবো, যে আমরা আর কিছু বার্নিং ইস্যুস আছে কিনা বলার মতো, আমাদের সাথে শেয়ার করার মতো, অথবা কোনো হিডেন কোশ্চেন আছে কিনা সেটা একটু জেনে নিলাম, তারপরে একটু প্ল্যান করে নিলাম এর পরবর্তী ফলো আপটা কিরকম হবে সেই বিষয়গুলো। একটা বিষয় আমরা অনেক সময় কমিউনিকেশন করতে গিয়ে অনেক সময় কি করি, কম্পেয়ার করি অন্যান্য রোগীদের সাথে, এটা যেন আমরা একটু না করি, একটু খেয়াল করবো, কম্পেয়ার যেন না করি রোগীদের সাথে, মেডিকেল জার্গন গুলো যেন ইউজ না করি, এবং ফলস হোপ যেন না দিই। এই জিনিসগুলো যদি খেয়াল করি তাহলে আমরা কমিউনিকেশনে খুবই ভালোভাবে করতে পারবো, সফলভাবে করতে পারবো। সবাইকে ধন্যবাদ। তাসনিম আপু, আসসালামু আলাইকুম।
ওয়ালাইকুম আসসালাম। Thanks a lot, Roshan Appa. Thank you all for attending the session. We could see many comments from your side, and we would like to inform you that the next session will not be held in next Friday because of Eid festival. We will let you know by email when will be the next session and the topic name and other details. If you have any question, you can ask here for within next 1 minute. Otherwise we will close the session.
Sorry, Tasneem, can I just clarify that? Because I think
Yes,
Eid
please.
is Eid not the following week, Tasneem? I know you're better placed to say, but I think next Friday is the 16th, and we do have a session on children's needs for palliative care. And the following week, there'll be no session. So next week, 16th of July, children's needs for palliative care, open session. Following week, Eid holiday. Is that correct, Tasneem, as well? Is that what you
Yeah.
understand? Eid is 21st, I think.
Yeah.
Okay,
Yeah,
okay.
Thanks for the correction, Catherine. It depends on the moon. It depends on the moon. So we are not sure whether it's on 21st. Please, anyone could correct me. So if we kept it on 16th, that's absolutely okay. We can announce now. 16th will be the next session. And after the next session, we will remind you that about the holiday session and other things and the next planning also. Thank you so much.
Yeah, it might be on 20th or 21st. So for that reason, for 23 Friday, there will be no session. And the next session will be July 13. But before that, July 16 will be, we have a session. Yeah, and we will invite you accordingly.
Thanks,
Thank
Said.
you.
Thanks, Said. And to all the participants, Bangla speakers, I tried my...
Tasneem Appu, Assalamu alaikum.
Walaikum assalam. Yes, please, Sumaya, we can hear you.
আপু ব্রেকিং ব্যাড নিউজ এটা কমপ্লিট করার পরে শেষে দেখা যাচ্ছে পেশেন্ট কান্না করে দিল, বলল যে তাহলে কি আমি এখন মারা যাব, আমি কি কখনো ভালো হব না? ঠিক ওই প্রশ্নের উত্তরে আমরা তখন কিভাবে তাকে আশ্বস্ত করতে পারি, এটা জানার ছিল।
Thank you so much, Sumaya. I will translate it. আমি এটা translate করে ইংরেজিতে বলছি. I hope any of our faculty member will respond. Sumaya got an excellent question for us. And that is at the end of the session of Breaking Bad News, there was a question that patient started crying. And from patient side, the question was, that means I will not live anymore. Could you please tell me that I no longer I will live in this world, and how do we tackle this situation? Would you like to answer, Megan? How to respond to this reaction?
Yeah, I mean, it's tough. It's just really sad. And, you know, we're not always there to fix things. We're there to support people and, you know, be with them. But we can't change the reality of the situation. So if the patient says something like that, I think we say, I'm really sorry. You know, it's really sad. Now, and sometimes you have to be careful if you say, I'm sorry. Like in English, I'm sorry means like, I feel sad. I feel your sadness. I'm sharing that emotion. You're not apologizing like you did anything wrong. So sometimes just make sure you translate that into Bangla in a way that's like, I feel sad with you. You know, this is really a tough situation. This is really not, you know, what I would have wished happened. That's what you're trying to say. And then you just sit and you just give them a minute to think about it. And normally what happens is people sit and they're sad, and then they kind of gather themselves and they say, okay, what are we going to do? You know, okay, I'm going to go home. I want to do, and you could say something like, what's important to you? And Aaron is saying, yeah, it's important to not say, you will not die. Like, we don't lie to the patient, right? We tell them the truth. If they say, so I'm going to die, you say, yes, I think that's what's going to happen. Okay. Remember, it doesn't help people feel better if you say, don't worry, or if you tell them a lie. They don't feel better. They feel worse. They feel mad at you, and they have a bad illness. So better to be honest, but then you can show support because you've made an honest relationship. And you can say, I know this is really difficult, or I can imagine this is really difficult. You know, what can I do to help you? Do you want me to talk to your family? You know, what's important for you now that you know your time isn't, you're not going to have that much time, you know.
Thanks, Megan. সুমাইয়া, আপনার জন্য আমি এটা বাংলা করে বলছি এবং অন্যদের সবার জন্য ধন্যবাদ। আপনি প্রশ্নটা করাতে সবার শোনার সুযোগ হলো যে এটার ক্ষেত্রে উত্তরটা কি হবে। অনেক সময় আমরা যেটা করি, আমরা মিথ্যে আশ্বাস দেওয়ার চেষ্টা করি, এমনকি আমাদের হেলথ কেয়ার ওয়ার্কারদের ভেতর এটা রয়েছে, না এরকম কিছু না, আপনি অনেকদিন বাঁচবেন। এই ধরনের কথাবার্তা আমাদেরকে অ্যাভয়েড করতে হবে, সম্পূর্ণরূপে এই ধরনের কথাবার্তা আমরা বলবো না। ইংরেজিতে যেটা বলা হয়েছে আই এম সরি বলার জন্য, কিন্তু যেটার বাংলা হচ্ছে আমি ক্ষমা চাচ্ছি, এরকম ব্যাপার না। যেটার বাংলা হচ্ছে আমার খুবই কষ্ট হচ্ছে আপনার খবরটা শুনে। এইটা বলার অর্থ হচ্ছে আমার কষ্টটা শুধু শুধু হচ্ছে না, আমার কষ্টটা একটা কারণবশত হচ্ছে। আর আপনি যে জানতে চাইলেন আপনি মারা যাবেন কিনা, যদিও আমার কষ্ট হচ্ছে, কিন্তু সত্য উত্তরটা হচ্ছে হ্যাঁ। তবে কি করলে আপনার কাছে ভালো লাগবে, আপনার জন্য আমরা কি কি করতে পারি, আপনার পরিবারের কার সাথে প্রথমে কথা বলতে পারি, এই বিষয়ে আপনি আমাকে নির্দেশনা দিতে পারেন। আপনারা কিছুটা সময় সাইলেন্স, নীরবতা অবলম্বন করতে পারেন রোগী গুছিয়ে ওঠার জন্য তিনি পরবর্তীতে কি বলতে চান। থ্যাংক ইউ। Any more question?
Saeed has put a question about quiet and facial and body expression, very serious. Finding a quiet place is important. Your facial and body expression, as Dr. Megan outlined, you're going to sit down if possible, have an open body posture. Yes, you should have a serious facial expression. Don't, try not to be nervous and anxious and laugh anxiously. That's inappropriate. So yes, you need to make eye contact, be serious, and have thought in advance what you're going to say as much as possible. And you can practice this with your colleagues. You can practice having these conversations. We do this in role play all the time, but practice it. And then it gets a bit easier. These are really hard conversations to have.
I think, Tasneem, if you can give the healthcare workers encouragement that as they learn to do this and as they do practice, even in real situations, we don't say that when we're doing real life situations we're practicing, but you do get better. So to have confidence, even after the first few times, talk to some of your colleagues that are on this call and reflect on what you've done. And I do think that you will get better at it. Yeah.
Thanks, Erin. During the COVID time, we got batch of training for people how to break bad news, and we did some role play also. Dr. Anna Vok, one of the palliative care physician from Canada, she gave us some website link where it was some conversation with serious illness people, even during COVID period also. And I tried to make some Bangla translation of this, and we exactly did the role play. I think a few of the participants from today's session also was present that time in that sessions. And from my side, I found it really helpful. And what you say to talk to my colleagues to practice it is not that common in Bangladesh to do practicing before you say something. But what I believe is it works really better. And I will translate this part in Bangla, that do practice before you speak to patient and the family. আপনারা আজকের কনভারসেশনে যেগুলো শুনলেন, যে কথাগুলো শুনলেন, অনেকের কাছে মনে হচ্ছে যে এটা আমি হয়তো বলে দিতে পারবো, অথবা এটা বলা এত সহজ না। আমি বলবো আপনারা এই কাজগুলোর ক্ষেত্রে আয়নার সামনে দাঁড়িয়ে, অথবা আপনি যার সাথে কথা বলছেন, আপনার বন্ধু বান্ধব, আপনার কলিগের সাথে আপনি এই জিনিসটা কিভাবে বলবেন কিছুটা প্রস্তুতি নিতে পারেন। এটা খুব ভালো কাজ করে আপনি সরাসরি রোগীর সামনে যে কথা বলার চাইতে যখন আপনি প্রস্তুতি নেন। আমি আমার এক্সাম্পল দিব, আমি কিন্তু যখন সেশনগুলো করি বা যখন একটা রেকর্ডিং করি, আগে আমি নিজের জন্য একবার বলে নেই, যাতে আমি বুঝতে পারি যে কোন কথাটাতে আমি পজ দিব, কোন কথাটাতে আমি থামবো, কোন কথাটাতে আমি বেশি জোর দিব, অথবা কোনো একটা কথা সম্পর্কে আমার আরো একটু বেশি পড়াশোনা করার দরকার আছে কিনা, আমি কোনো রেফারেন্স দিতে পারবো কিনা। সেরকম হলে আপনাদের জন্য ভালো হয়। I think we can close the session now. Thank you so much.
See you next week.
See you next week. Take care.
আবার দেখা হবে।
ধন্যবাদ। Bye.
Bye.